Buckley. I'm the chief of genetic and genomic medicine here at Children's. Welcome to Grand Rounds. Whether you are joining us in the Rangos Auditorium, where I am, or somewhere else virtually, we thank you for taking the time to attend this special presentation. As a reminder, for those of you who are online, there's not a separate link for the meet and greet today. It will be integrated into the lecture at the end. If you'd like to ask our speaker a question, please type it into the Q&A. If you'd like to engage with the presenter, which I highly recommend, ask the webinar host to unmute or give you access to turn on your camera. If you're attending in person and would like to engage, just raise your hand and hang out. We'll bring you a mic. We also have posted the QR code for today's Mock 2 quiz on the back desk. Let's see, by the door for those of you who are in person. Otherwise, you got it online. We're honored today to have Dr. Charles Venditti here to present Grand Rounds. Chuck joined us yesterday for our Center for Rare Disease Therapy, Gene Therapy Symposium, and just presented remarkable work on his development of gene therapies for this group of disorders. Chuck is an MD PhD. He's a senior investigator in the National Human Genome Research Institute and the chief of the molecular medicine branch at the National Institutes of Health in Bethesda. As a clinical biochemical geneticist and laboratorian, he's developed a translational research program to study the natural history and clinical phenotypes of the hereditary methylmalonic acidemias, cobalamin metabolic disorders, and propionic acidemia. His research group is developing gene, cell, and small molecule therapies to treat MMA and PA. Dr. Venditti has received a number of national and international awards, including the Presidential Early Career Award for Scientists and Engineers Award, which is the U.S. government's highest honor for early career scientists. And he's an elected member of the American Society for Clinical Investigation. He's authored and co-authored more than 130 peer-review research articles, reviews, and textbooks chapters, and he is a named inventor on 21 U.S. patents. Today, Chuck's going to be talking about inborn errors of vitamin B12 metabolism, natural history, pathophysiology, and treatment. So let's see, are you back here, Chuck? Where are you? We lost him. I hate it when that happens. Take over, please.
Okay. All right. Now I talk, right? Yes. Okay. Well, thank you very much for the invitation to be here. It's really an honor to come and deliver Grand Rounds. It's part of my roots in pediatrics, and I remember it well from the 1 hour reprieve I got when I was an intern and resident years ago to come and attend Grand Rounds. So hopefully people will get something out of this. And if you're post-call, you're not going to be here falling asleep, but please, I understand. I'm going to talk about something I've been studying ever since I've been a fellow in metabolism at the Children's Hospital of Philadelphia, something that's held my attention. Mainly, in some ways, it comes through general pediatrics, which is newborn screening. That's how I got interested in this. And so for the general pediatrician trainees in the audience, this is an incredibly important thing you're going to do when you practice. You are going to be a point person, depending on where you are for newborn screens. You might actually be involved with the management of patients that have metabolic disorders. So with the prelude of that, this is going to be a very heavy focused talk on inborn errors of metabolism. And I'm going to try to provide some pearls for general peds and subspecialty trainees as I go through my talk today. Let's see. Slide. Okay. I do have some disclosures. This is related to work. I'm really not going to present a lot today related to development of genomic therapies for methylmalonic acidemia mud type, which I'm very proud to say I'm here. And with Dr. Buckley and his colleagues, this is really a premier center for this. And I think this is going to be, again, a very important part of pediatrics, is the delivery of new genomic medicines to our patients. It's going to happen in peds. It's already happening. And I'll make a comment at the end about a paradigm that's setting the sort of the precedent for the field, I think, as we go forward with newborn screening and beyond in pediatric and newborn medicine. I'm lucky to have a wonderful group of colleagues and collaborators at the NIH, which I guess I can't. What's the easiest way to get out the laser pointer on the screen? Does anyone know? While I'm getting oriented here, I just wanted to show a picture of my group. And
here, you can just grab it here.
Oh, there we go.
And now if you show it here,
Okay,
it'll
there
show
we
up over there.
That's why he's the chief. Thank you, Jerry. No, this is I have a wonderful group of colleagues that I've been working with for many years at NIH. And part of what I've learned over time about developing a program that's productive is to have a number of people that are invested in myself and a number of wonderful clinical colleagues who it's amazing to train them and see them become really world experts on their individual areas of expertise. And I'm honored to be a part of it in the training process. And of course, all my patients and collaborators from around the world. So today I wanted to go over a few major topics for the audience, which is to review the clinical sort of manifestations of the hereditary methylmalonic acidemias. I wanted to spend a minute to talk about disease mechanisms. We're not going to be able to dwell in great detail on this. And then to talk a little bit about the treatment approaches, where we're at, sort of a critical reassessment of some of the therapies we use, and then things that are, I still, considered quote unquote experimental, which would even be surgical treatments, and then the real experimental stuff, which is going to be genomic based therapies. So I've been practicing medicine at the National Institutes of Health and the Intramural Research Program. That's a picture of the NIH Research Hospital for those who've never seen a picture of it. And it's a really special place where basically every patient that comes in is on a research protocol. And so over the years, we've seen many, many patients with MMA and cobalamin disorders. This is a little bit outdated. It's probably more patients than this, but you can see the numbers. The mutase type of MMA is the most common type we've seen, and in the population, this is true as well, with around 85 or more patients. And the cobalamin C defect, which is a combined form of methylmalonic acidemia, hyperhomocysteine, which I'm going to talk a bit about today. This is actually quite a common condition, and we're following about 92 patients, and probably I receive inquiries about this every other day from all around the world because of the mysterious complications that can accompany this disorder, including blindness, which we don't know what causes the cause of it is yet, or how to treat it. So we've been able to make a number of really interesting observations. I won't be able to go through all these, but there's some great vignettes here of clinical research, and I will go through one on dietary management to illustrate the importance of doing clinical research and always being critical. Whether you're doing general peds or subspecialty medicine, you always have to be critical of the current temporary practices and come back to the question of, what is the evidence for what I'm doing? Is it going to help the patient? Is it scientifically proven? This is, no matter where you are in medicine, this is an important perspective to keep. And I'm going to share something we've developed, some observations we made about dietary management of MMA. So to get right into this, the hereditary MMA syndromes, and at this hospital, I know that the clinics here, I imagine you're probably following 10 to 20 patients with this. So if you're in general peds, you will be probably assisting with the metabolic genetics service and admit the patients. They come to the hospital not that infrequently. The MMA syndromes are heterogeneous. I'm going to go through what that means in a minute. There are a group of inborn errors of metabolism that affect vitamin B12 metabolism because one of the enzymes is vitamin B12 deficient, two actually. And they're very, very severe in the untreated state. And the reason, again, to illustrate the importance coming back to pediatrics, these are detected, these conditions, this and many others, are detected on day of life 1 to 2 on the newborn screen. Now, you might not get the results back till day 5, and that's a separate debate. But every baby born in the US is screened for a variety of metabolic disorders. And again, in pediatrics, this is incredibly important because when you go on to general peds and you get a fax or an email or an alert from this newborn screen lab, you have to understand that not all disorders are the same level of urgency. So when in doubt, you must call your referring physicians, because I've seen patients where there's newborn screen positives for organic acidemias and fatty oxidation defects. Those are emergencies. You can't wait. You can't triage that to a nurse and have someone call tomorrow. You have to act immediately. So this is a paradigm shift in, I believe, in newborn medicine. Overall, these disorders are about 1 in 50 to 1 in 100,000 incidents, and they have these massive metabolic perturbations that are characteristic. And if you're on the general peds side, I would not probably do any metabolic workup right away. I would call your referring center, and after you assure the patient's stable, then go to the next steps. So it is important, again, to think about as we think about these conditions, to put them in perspective. The enzymes that are defective in these pathways depend on cobalamin at the very end of the pathways. And so cobalamin metabolism, this is vitamin B12. There's been multiple Nobel Prizes awarded over the years for determining what vitamin B12 was, the structure of it, what the enzymes are, the synthesis of it by Corey. It's an essential micronutrient. And we must obtain this from our diet, from animal products. So again, thinking back to general peds, if you're seeing a baby of a mom that's born, a vegan mom that's not supplemented, that baby can have a vitamin B12 deficiency. What we know is some of those infants, if it's a severe condition in the mother, have a severe neurologic and biochemical genetic presentation, and they can look frankly encephalopathic and have a difficult outcome if it's not quickly reversed. So you can see here in this little box, in infants and children, these are the things to pay attention to. Anytime you're seeing someone with FTT, do not forget to work them up for micronutrient deficiencies, especially vitamin B12 deficiency. And there's an interesting twist on some of this. Some patients that can look exactly like nutritional defects can actually have inborn errors of metabolism. In the olden days, if you did something called the Schilling test, which people in the audience I'm looking at are so young, maybe don't remember that one, but some patients will look just like a nutritional deficiency. They'll actually have a Schilling test that looks like they can't absorb, and they could have inborn errors of metabolism. So keep this on the differential, especially in FTT. And in older children, again, this can be, when you see this, probably not as common in the US, but neurologic and hematologic problems accompanying this. In adults, it's quite common. And there's a lot of reasons this can happen in an older child or an adult. And you can see the list here. The ones I think you have to pay attention to are nitric oxide abuse. That's an abused drug. And so you can see people that really have symptoms from this. Dietary deficiencies are common. So you think about patients who maybe have an anorexia bulimia syndrome. They're not getting nutrition. They're not going to get animal products. They can have vitamin B12 deficiencies. Autistic patients that have funny diets can have this. And it can make everything worse. In the frank state of a vitamin B12 deficiency, it really is encephalopathy, and it can involve all these different things. If you want to read really more about the details, this is the best review that Dr. Stabler wrote, 2013. The last thing on the differential is what I'm going to dwell on now, metabolic disorders. That's really the focus of the talk today. So vitamin B12, for those who just want to remember this for your boards, it's on every single board test. It's going to be on your PEDS board. It's on every test you'll ever take. They're going to ask you about this. There's two real active forms of vitamin B12 in human metabolism: methylcobalamin and 5'-deoxyadenosylcobalamin. These you can get in your diet, but they won't do anything. You can't just supplement this and think if you take methylcobalamin, it's going to produce methylcobalamin in your cell. What we take in our diet are the inactive forms. Usually the moiety here is cyano, which actually was part of the original structure B12, or hydroxycobalamin. And that's metabolized into these, which are the cofactors for the methylmalonyl-CoA mutase enzyme. That's this, and methionine synthase. So those are the two vitamin B12 dependent enzymes in human metabolism. So when you see that on the test, methylmalonyl-CoA mutase, methionine synthase. Remember that. It will be on your test forever and ever. Okay, now we're going to start digging into what this really means. There's our cofactor, adenosylcobalamin, and here's a step of the pathway we're going to focus on, which is the conversion of L-methylmalonyl-CoA into succinyl-CoA. And here's, again, something that sometimes for those in genetics and metabolism, you will be expected to know these types of things, which are where the precursors come from. And this is a mnemonic that I did not come up with, but, odd chain fatty acids, branch chains, this is not a branch chain, and methionine, and then from the gut, propanil, flora from the gut produce propanil coenzyme A, which is probably the toxic starting metabolite, which brings all other things with it. And you can see here, these are the main enzymes of isolated MMA: methylmalonyl-CoA mutase, MMA-A deficiency, which is a vitamin B12 responsive form of MMA, and cobalamin B deficiency, which can be responsive, usually is not. Now, cobalamin metabolism, as I mentioned, let me just get this clicker over here, is a little more complicated because there's multiple steps that get the vitamin into the cell. And when you can't do any of these metabolic steps, these are the different enzymes that can be aberrant. And for example, a block at this step will cause this enzyme to not work. There's our methionine synthase enzyme that does the remethylation of homocysteine to methionine. So patients will have an increase in MMA, and they will have increased homocysteine and low methionine. So these are patterns you must look for when you work the patients up. Again, for the general ped side, I would not do this without a consultation because it's not always the case of these metabolic perturbations. And there's other forms of MMA which can cause increases in the methylmalonic acid in the blood and urine. And one of them that the neurology colleagues must know about this one is the succinyl-CoA ligase synthetase defects. These look like they are Leigh syndrome. These patients have low levels of MMA, and they have usually a very difficult clinical course of Leigh disease. And then there's other conditions that are involved with salvage pathways, which I'm not going to discuss today. So digging in even more, let's continue to emphasize this. There's forms of isolated MMA. This condition I'm not going to talk about. This is a rare one, but it's probably severe. Interesting. Some patients with this have true isolated MMA, hyperammonemic coma, death, very, very severe. And in the same family, you could see a patient with this condition. Again, this is the mystery of inborn errors of metabolism and not be as affected and perhaps be asymptomatic. Again, the ACSF3 deficiency syndromes, there's complexity to this. We've just discovered a related form of this, which was puzzling in our first foray into figuring out the ACSF3 deficiency syndromes in humans, because some patients had this and were very, very severe in our original reports. And we could never figure out why. They didn't have mutations in the ACSF3 gene. Well, it turns out they have a mutation in this transcriptional co-regulator that regulates this metabolic enzyme. And these patients that have CBTB11 deficiency have a really unusual form of microcephaly, cataracts, and methylmalonic acidemia with malonic aciduria. So again, this is not for biochem genetics orientation, but there's heterogeneity, the genes and the biochemical phenotypes. So these conditions really do illustrate that, and that's why I'm mentioning it. Now, as we look at the isolated hyperhomocysteinemias, again, these patients have high homocysteine, low methionine. So for those who want to know about homocysteinemias, this is one class of them. The other class has high homocysteine, high methionine. It's a separate defect. Very different treatment approaches. But later on, I'm going to tell you why they have a deep connection to the homocysteine hypothesis of human metabolism. And these patients that in the severe forms are extremely difficult to treat. They many times have neonatal presentations. They can have congenital microcephaly. They can have renal syndromes, terrible renal disease, persistent macrocytic anemias, plus or minus seizures and neurologic symptomatology. So you can see these patients in the nursery, in the delivery room, sick right after they're born, and then presenting with a variety of infantile and pediatric presentations, usually neurologic and hematologic. And they can be extremely difficult to treat in terms of getting them under control and symptom management. And then there's the group of patients in the middle that are quite common, the so-called combined defects. These patients have a problem metabolizing cobalamin, and they have methylmalonic aciduria, hyperhomocysteinemia, and hypomethionemia. They are always vitamin B12 responsive biochemically. The debate is how much the clinical symptoms respond and why is that? It's not known. Now, this condition itself is heterogeneous. Most patients will have a defect in the MMA-CHC gene causing the so-called cobalamin C deficiency, the classic type. But within this group, there's patients that actually have an epigenetic defect of a cis gene, but it takes out the MMA-CHC gene. Those are patients who have what's called epi-CBLC. So here's a real paradigmatic example of epigenetics in medicine. And yet there's another group of patients that have regulators. And these patients, again, are going to come through the neurology service usually, especially the patients that have cobalamin X deficiency. They have infantile spasms almost always, and they're very difficult to treat. The biochemical defects can respond to cobalamin, but the seizures usually do not. And these patients have a severe phenotype, this group of patients, which I won't talk a lot about, but it's on the differential. Some of these patients have even presented with hyperammonemia, and they can have increased C3. They don't always have it, but they make the enzymes, so they're very responsive to cobalamin. I won't talk more about this, but it's a fascinating example of, again, complexity of inborn errors of metabolism. The trigger here is going to be an increase of a metabolite. The genetic mechanism is very complicated. So these are the conditions that are being screened for. And again, I just learned yesterday, CRABA made it to the back to the PA list, which is a separate debate in itself. But on the newborn blood spot, these conditions here are all forms of MMA. There's propionic acidemia, and that's a limited list. So I'm going to try to go through a bit about these today and give a bit about the history of them and how to treat them. So one thing that people always want to know about is, how common are the disorders? How do you figure that out? This is a clinical epidemiologic problem. When you're looking at rare numbers of rare disorders, what's your N needed to get a real answer? And so the best study I know of came from 4.5 million babies screened over about 10 years in California. And these patients received biochemical genetic screening and then also exome sequencing, because metabolic perturbations, that's a screen. There's a differential diagnosis that entails after you have a positive newborn screen for a metabolite. And you can see here's the distribution. I'm not going to go through them all. But if you just look and sort of pile them up, as predicted for many of us, Dr. Valkley here is a fatty acid oxidation, guru, expert, long been known and suspected that MCAD deficiency was quite common. And indeed, it's the case. 146 patients are diagnosed by this method. This doesn't account for false negatives, by the way. PKU, the classic form, 46. And if you put together MUD MMA and other forms of MMA, about 40. So MMA is, rare, but it's not that rare. So what happens when the screen is positive? This is getting into, what would you do? And here's what you would do. If you want to really read about this, there's a wonderful article that Dr. Manoli wrote in Gene Reviews. It goes through the algorithms, what the things you would want to get in the patients, and how you would arrive at the diagnosis for a patient eventually. Sorry, give me 1 second here. So the first thing you must do, and again, just to emphasize this to those practicing in neonatal medicine, general pediatrics, this is an emergency. You don't wait on this. If you find out the screen comes back, you stop everything and you start figuring out what to do. The patient could have hyperammonemia and could have a serious brain injury unless you immediately act on the patient to try to treat them. Some need dialysis. You have to be really careful. And you have to start aggressive management for the patients. You must know what you're doing here. You could potentially get a serious AE. Now, the metabolic labs could include some of these. And these are things you could get potentially quickly, depending on what state you live in, for second-tier screening. For those out in the community, maybe you could get some of these labs quickly. Do not forget to do this ever. You must check the patient's B12 level and always try to get the mother's B12 level, because patients that have certain inborn errors of metabolism can have low vitamin B12. And if you start injecting someone and you don't know, you're going to be treating that patient for their whole lives, potentially. And they could have a nutritional deficiency. You have to be really careful about this. And then you're going to be in a situation of improvement. Then do I withdraw the medicine? Does the patient have something? You can do genetics. You're not going to find an answer. It's really a mess. So always, always, always remember to do this first step. And it's hard sometimes, because if you're sticking a small baby and they're sick, you might not get enough blood, but this is critical. So please, consult metabolism and genetics, but remember that one too if you're on your own in an emergency room. Some patients have lactic acidemia. That's profound. That's not specific at all. And don't forget that newborn screening is a screen. So for those in neurology and genetics in the clinics, just because a patient has a negative newborn screen does not mean they don't have a condition on this list. They exist. I've seen multiple patients who were missed on newborn screening and presented with symptoms, and people hemmed and hawed a bit sometimes because, the newborn screen was negative. Don't fall into that trap. It's a screen. Use your clinical instincts. Work the patient up if they have the symptoms. So when a patient has MMA, they have a lot of symptomatology, and it's diverse and it's mysterious. I'm showing you some of the things that are considered more chronic complications. And they're difficult to manage in some patients, extremely difficult. Some patients, for example, get recurrent pancreatitis, and it can be hemorrhagic. I've had a number of patients in our study die from this. It's extremely dangerous. We don't know why it happens. Some patients seem to get it more than others. We've done the genetic panels. It's mysterious. It's not a second gene that's mutated in these patients. But they always, always get metabolic instability. And this is why you have to have great caution. And again, I would say this to anyone from the emergency room that's listening. And I'm certain at your institution, you know, this is a high priority triage case. So when patients come in, they can look well, but I've seen this happen in very famous children's hospital institutions where a patient has this and they're heading down to have a metabolic decompensation. And someone says, well, their respiratory rate's fine and they're breathing, you know, their O2 sats. Well, you take their shirt off and you see you're starting to use accessory muscles and the breathing pattern's a little bit abnormal. And then 30 minutes later, there's deep respirations and the rates are going up. So this is very dangerous and you have to be careful when you're triaging patients. You can't just have someone say, vital signs look good, put them in a room, I'll see them in an hour. Do not do that. Take the shirts off, be careful, just do the general pediatrics assessment that we all were trained to do and be super vigilant of these patients. I've seen patients go downhill in hours in front of people in emergency rooms. It's very common. So when a patient is severe, there's, you know, this is part of the mystery of medicine because the treatments that I'm going to talk about involving transplantation involve clinical instincts sometimes. Is a patient severe or not? Do I want to give that child a very early liver transplant or not? These are hard, very hard decisions, and they can literally be life or death for the patients. But things that we think about are, you know, the nature of the molecular genetics, how much enzyme activity they have, how early they're represented. If a patient's coming out, and I've seen patients, again, in mice, and I'll tell you a bit of just a foray about mice for a second. One of the first things I did when we were making genetically engineered mouse models, because this is seen in humans, mice with methylmalonic acidemia on embryonic day 18 have a blood MMA level of around 200 micromole. That's about 1,000 times normal. So patients can be born intoxicated. You have to really be careful of this, and that tends to be more severe. And that's a very important thing to think about in the clinical history when you're evaluating someone, especially hyperammonemia. Although patients, I will say at the same time I say that, I will tell you that patients that are mild and B12 responsive can also present in deep comas and be hyperammonemic and be reversed by vitamin treatment. And then if they respond, and this is an older approach because we don't do this that much anymore with enzymology. Now, what's happening over time to the patients, you know, this is a study that is a retrospective amalgamation of many patients in the European centers. You can see that the type of enzyme diagnosis the patient has, the MUT0 type or the non-B12 responsive cell in the cell, they do the worst. But over time, probably with an effective newborn screening and that, you know, recognition, patients that have the severe enzyme defects are doing better in terms of survival. Doesn't mean they have great quality of lives. They're surviving. Now, what we do know is that no studies I know of have taken into account organ transplantation. So if you're getting very severe patients on this end of the curve and you're treating them with liver transplants, you're going to convert them to being alive. But that's really not reflected in the survival curve. You will see that patient living, but you will not know that you did, say, liver transplant or gene therapy or RNA. So this is a very gross description, but it's encouraging that patients are doing better over time. But still, there's, I think, a lot of work to do. Now, I talked a bit about this, and this is, again, part of the CME credits or the questions in there. You must try to determine if a patient's vitamin B12 responsive. Patients with the cobalamin A defect, which really isn't as much as on the side of the graph over here. These patients are about 25% of overall isolated MMA patients. They always respond to the vitamin. If you don't treat them with the vitamin adequately, they're going to look like this, especially kidney disease. So this is a big thing to determine. And don't go at this by yourself. Get a consult for this because there's a debate about how to do this properly. But this is very important to know. If you're vitamin B12 responsive, either enzymatically in the dish or clinically, you have a much better prognosis. And it means that if you have small amount of residual activity, i.e. if you could restore that with gene or cell therapy, you're going to have a better outcome. That's my interpretation of that observation. So how do you treat the patients? It's hard because a lot of the metabolites come from here and we can't get rid of those, especially the gut flora and auto-oxidation and diet effects. We're trapped with that in humans. And this is difficult. So what do? You protein restrict the patient, and then if you protein restrict someone too much, you get malnutrition. I've seen patients that look like kwashiorkor because of this. They might have lower levels, but they're doing horribly usually. So that's a debate about, you know, how much protein to give and when and why. I don't want to get into that now, but it's a debate. We can give carnitine. This is what people would say. Maybe it does. I don't know if it's still debated and how much of an effect you get from this. is small. You can try to get the Krebs cycle working better. Small effects, but good. Use citrate. Don't use bicarb in your patients, please. I think there's a second benefit for giving citrate to base replace. And then you could try to target the mitochondria because that's a source of dysfunction. Again, all these things are small. This, in terms of the clinical effects, this is the most important. A patient that's not on diet is going to do much worse than anybody else. These things are, I'm not saying they're not important. They are, but, they have effects. But, again, how strong they are, debated. And then, if someone's in very, very deep trouble, you can give them Carbaglu. The acute setting, I've seen patients on this chronically, and I usually just say to the moms and dads, is it helping? And they say, no. So sometimes when I hear that, I think you don't need a heck of a lot of more studies in patients when the parents are super attentive. Certainly if someone's sick with hyperammonemia, Carbaglu can help the patient. And the mechanism of hyperammonemia, I won't talk about that. I talked about it yesterday. It's mysterious, probably related to post-translational modifications of urea cycle enzymes, potentially not due to a NAGS effect. And then, of course, you can do the ultimate, liver kidney transplant. That's the big sledgehammer to do for these patients. And whether or not we can do better, that's part of what we're doing here today, is thinking and learning together about alternative approaches. I'm not against transplant. Nobody is. But if there's something you could do that could be almost as effective and maybe give that organ to someone else, we should think about that. There's not an infinite supply of organs. So people want to read more about guidelines. And again, this is a separate debate. The European groups tend to publish a lot of these guidelines. And what it is tends to be a number of experts together reviewing papers and writing down sort of best practices in metabolic medicine. It tends to not be evidence-based. Unfortunately, just part of the limitations of the small numbers of patients, lack of trials. But nevertheless, these are important guidelines for people to look at and help give some information about your patients. What the hot button topics that sometimes these guidelines don't address are things like transplantation, therapy, dietary controversies, cobalamin escalation, and this is the real deal. What you do in the clinic is struggle with those things. Nevertheless, they're very important resources for the community. They tend to be overall, I think, useful. So let me just get the pointer back over here. Okay, there we go. So the management of MMA. Now I'm going to switch over and start ripping through this. What has changed? And this is a vignette about clinical research. So this is what you do to manage patients. You give them a formula and you give them this nutritional supplement. It's a medical food. You can't just go buy this. You have to prescribe it. There's a reason why. Because if you just put someone on medical food, they will die. They're not complete proteins. So we were seeing patients that were on these special diets, and many were taking isoleucine and valine supplements. So remember, isoleucine and valine are propriogenic. They cause MMA to form. And in the old days, when patients were being challenged to see provocative challenges, that's how you made them very sick, is give isoleucine. So why the heck would patients come in on this? That was the mystery. This is part of clinical research. I'm going to tell you why. And it came out in this paper that was done by my brilliant colleague here, Dr. Manoli, who really figured this out. And it is related to what we do. It's iatrogenic. We are doing this to the patients. And I'm going to tell you why we do, how we do it. Anyways, when we publish this, then this is a note of caution to anybody in the audience. If you publish papers, just be careful. We had all these meetings at NIH about release of information. And once the information is released, people can write whatever they want. Because we wrote this article and we had a press release about it. And someone said, well, we can't say this, we can't say that. It's, it's going to be, FDA was involved. And then as soon as we released this paper, someone writes down here this crazy article that, what we're saying here is this, it's really toxic and we're causing brain damage. And it was completely twisted. So just be careful. There's different interpretations of this. So when you do your press releases, you get your experts involved, but you can't control the public. You can only stay in front of it. So our patient cohort that we use to do this observation, this speaks to the importance of organized clinical research, I think. For me, this was one of the most important lessons I've learned in the years. We had a very diverse cohort of patients from all around the US and all around the world. So we could see patients treated one way, another way, a different way. And we would then analyze them over a week. And we would do all the studies, the molecular genetics, the characteristics and metabolic measurements, all sorts of research-based medicine things that are super important to keep doing. Many of our patients were severe, and we really characterized them thoroughly. This is incredibly important for heterogeneous conditions, whatever your condition is. You must be careful about this. And what Dr. Manoli did when she brought them in and said, okay, here's our patients, very simple. Here's their intact protein load, and here's how much people are getting from medical foods. So now let's take a look. Let me just go one step forward. Okay. Let's take a look at some of these patients. They're getting way more protein than they need to grow properly. These are not people that are running marathons. These patients are hypoactive. And they're getting a tremendous amounts of medical foods. That gives calorie and amino acids. And if we look, even this is how many 200% DRI. This is what an American football player would need if they were trying to bulk up. Patients don't need this. And then what was really perplexing is some of them were taking isoleucine and valine. How the heck could that happen? This is insane. And it's really a real phenomenon. Like, let's take an example. Like, let's look at this patient. They're getting over DRI. They're getting a generous amount of medical foods. They're over 200%, but they're taking isoleucine valine. Boom, boom, another one, this one, et cetera. So it's just totally paradoxical. Why would this happen? And it's very bad because this produces a nitrogen load. Patients have renal disease. They get hyperammonemia. If you're prone to hyperammonemia, you don't want to take in a lot of amino acids. The nitrogen turns into ammonia. And it's expensive too. And this is real. Here's a patient who looked like ILU deficiency. They have skin and hair loss. It really looks real. The patients do have a deficiency. Why is it happening? Well, this goes back to sort of fundamentals. Take a look at the formulas. And this is, again, what Dr. Manoli did, broke them down. Here's our infant MMA PA formulas. Massive, massive amounts of leucine. Remember, leucine, isoleucine, and valine exist in nature in almost all circumstances in a very controlled ratio in medical foods throughout all states of health and disease. This is totally bizarre. There's no ILU or valine. And if you look at the leucine intake in these patients, it's absolutely 5 times DRI. It's huge. So what's happening in the patients, and I can't go through this, but the leucine load has an effect. Leucine is an interesting amino acid. It has signaling properties and it has effects on growth. It has the following effects. It stimulates BCAA oxidation. And in humans, that's the muscle bits, usually. So what's happening is the unbalanced leucine load is driving oxidation of ILU and valine. The patients are coming in and you measure the levels, they're low because of this. It has a second effect that's very bad, which is it blocks branch chain uptake into the brain. And we saw patients with CBLC getting medical foods. So overall, a very dangerous combination. And it was because when people made medical foods, they just didn't think of this. They took out valine and isoleucine and said, we'll just add back more leucine. There was no research being done. And no one did anything. They just said, well, it looks pretty safe. Keep giving it to infants and children. It's toxic. So this helped us reformulate guidelines for treatment of patients and also develop new guidelines for propionic acidemia. So I just wanted to share that vignette about why clinical research is so important. And it always must be done. And you always must challenge the paradigms, no matter if it's a rare disease or common. Very important to do always. Okay. Let's move on to another topic of great debate and contention, which is liver transplantation and transplanted in patients. So you can see here, this is really just, who would get it. CBLB patients, by the way, can be very severe. They can look just like the most severe mutase patients, MUT0s. These patients, when you start seeing this, you start thinking liver transplant early. Some patients are intermediate and you can maybe wait it out. This is a debate about, can you wait out an LKT? There's pros and cons to this. And then there's some patients that are mild and maybe you want to just consider a kidney only. This is again, a debate. There's no real hard guidelines about this. Now, when you have a liver transplant in MMA patients, it really eliminates the metabolic crises. Top centers like this have low morbidity and mortality. It does have clinical symptom improvement in most patients, not all. But there's surgical complications. I've seen a number of patients have rejection problems. Some people need to get retransplanted. There's some vessel issues that the surgeons can discuss. They need to be immune suppressed. Very bad. And I've seen patients develop this, a number of them, the post-transplant lymphoproliferative disorder. That's a form of lymphoma. And you need to treat that with biologics and chemo. Very dangerous. And I've had patients have severe complications from this. And it lowers the metabolites, but this is, again, another, don't be fooled by this. And don't ever tell patients that their MMA is going to go away. This is one of the very first observations we ever made in patients when we were studying them at NIH. Here's some data from actually your center here at Pittsburgh. It lowers your metabolites. But if you go from 10,000-fold 10,000 times to 1,000-fold, you're still 1,000-fold up in the limit normal. That's not a normal metabolic balance. And part of this is affected when you transplant and you do, especially kidney, but the renal physiology has a massive effect on levels. So don't just go on levels. What will be fully normalized in all transplant patients of the liver is their ability to oxidize propionic acid independent of their metabolite levels. That's why we do this in every patient, and especially in our gene therapy mouse model studies, and we're going to do it in humans too. And it doesn't present CNS complications. I've seen multiple patients have strokes, what looks like Lay-like disease after liver transplant only, and we don't know why that happens. Now, if we look at the cohort we're following, which is quite large, around 40-something patients, all from all around the world, different centers, different approaches. That's the distribution we see. And then we also see this. We haven't published this. Late mortality. So transplantation, it's really helping, but the patients are still dying. So probably there's always going to be a need for better treatments, and whether or not we should be doing something very early gene cell-based therapies, and then moving to transplant older patients to just keep shifting this curve out. So this is now going to be, instead of 40 to 50, we're going to say 60 to 70, et cetera. Food for thought. So why are the conditions difficult to treat? There's no debate about this. And this is something that, Dr. Walter wrote years ago, and it's really just so simple and accurate, which is, he just says, how efficacious is it? It's really not. For organic acidemias, it's hard to treat these patients with diet. And there are a bunch of reasons why, but there's other reasons why. Deep reasons why. They have mitochondrial dysfunction. Here's some studies we published and others looking at megamitochondria formation in the different organs, including the retina. Some patients go blind. There's impaired mitophagy. This is a publication that came from the group in Belgium. Very nice paper here showing probably there's a mitophagocytic response that's defective in MMA. Mechanism unknown. And then there's this, coenzyme A accretion, which I won't go into the metabolic sort of theory on this, but it's what it sounds like. If you accumulate lots of these, they can do toxic things inside cells. They can inhibit and they can modify. It's two sort of bad things they can do. With respect to modification, this is sort of a new insight I think we have about MMA. With these acyl-CoAs, can have non-enzymatic modification of lysine residues inside the mitochondria, especially. And when you isolate different proteins with this new modification we discovered in this work called methylmalonylation, you produce negative effects on the target enzymes, including enzymes of the urea cycle, et cetera. So in our paper, we have this nice model for those who want to see this and read about it, describing some of the secondary effects that we know can be we believe, due to modification, PTM, aberrant modifications of some of the targets that explain things like mitochondriopathy, glucose metabolism, hyperammonemia. The reason patients get high glycines, energy metabolism related to Krebs cycle, there's even more of them. There's actually hundreds and hundreds of hits, and each one begets a different pathway and mechanism. So we're trying to wade through that and figure out which ones are clinically significant using a combination of mouse genetics and gene therapy. So I'm going to switch now to cobalamin disorders, because this is for this audience, I feel like this is very important to sort of cover this. Remember, to go back to intracellular cobalamin metabolism, that's our pathway we looked at. The CBLC defect, this one is most common and most important. I'm going to say a few words about that now. Basically, there's a number of theories why this can cause problems in metabolism. I'm not going to go through them, but I listed them on the slide. Pleiotropic effects. One that's very well recognized is this one, which I'll say a word about in a minute now. So what happens when a patient has this condition? Well, they have lots of symptoms and signs. Some are mysterious. For example, this. Why do patients get this peculiar maculopathy? It's very severe. We published a study on the natural history study in our patient cohort. Most patients with severe genotypes were blind by the age of 10. So this is a serious problem for us. We're screening patients, we're treating them, they're going blind by the age of 10. It's not a good outcome for someone who screening is supposed to prevent that. So this is why you must do the research to figure out what's causing it and how to prevent. Now, for the neonatologists in the audience, do not forget this one. It is on the list of intrauterine growth retardation. Severe patients are almost always growth retarded, and they have microcephaly. And it's very typical, you'll hear a story of, mom's pretty certain about the dates, baby does, maybe baby looks like a 36-weeker and, should be a term baby. Quite common with a small head and doing poorly too, by the way. The patients can have heart defects. And very first patient, one of the early ones we published on had fetal heart drops, not fetal heart drops. And how these patients can develop terrific cardiomyopathy and actually have heart failure, heart transplant, and fetal heart drops from it. Who cares about this? Well, I'll tell you what, if you don't remember anything from this talk today, for those who are listening, tune in for this 2-second soundbite. I'm showing you the original publication on the homocysteine metabolism hypothesis of health promoted by Kilmer and McCulley in the 1960s. This paper had the foundation in 2 patients. One had cobalamin C deficiency. The other had CBS synthase, cystathionine beta synthase. That's another type of homocystinemia. And he writes in the paper, I'm not going to read it, but you can see what he talks about, how this pro-atherosclerotic event. And, last night when I checked, there was more than 10,000 citations when you put in homocysteine and cardiovascular disease. And it's coming from cobalamin C deficiency. And at the time, the patient wasn't even really known to have it. They were the index case studied by Harvey Levy and the late Dr. Mudd. So this is important. Patients can have other types of presentations. And so for those who are practicing, especially in neurology and in general peds, FTT plus or minus neurologic signs plus or minus hematologic, always think about this. If you're an adult side, neurocognitive deficiencies and cord syndromes, most common. And then frank encephalopathy, plus or minus patients can have thromboembolic events like strokes, heart attacks, and DVTs. Now they have this eye disease, these are the children, which is very severe. I'm showing you a picture of what it looks like. It's a peculiar finding. So for those taking biochemistry boards, bullseye maculopathy, cobalamin C is the answer. There's actually a differential, but this is the most common cause of this. And it's very severe. If a patient develops a bullseye, what that is basically the cells in the macula just being blown away and they're dying off, and they eventually die off, and you have this maculopathy extends. You end up having a peripheral retinal degeneration syndrome with spicule formation and the salt and pepper-like pattern with optic nerve atrophy. The visual prognosis here is poor, blindness. And this can happen despite treatment. So this is a challenge. How can we stop this? We've done studies on this, and again, and our results show that by the age of 10, most patients are legally blind. Patients can also develop a non-compaction cardiomyopathy. This is under-recognized and can be severe. I've had involved with a patient who needed a heart transplant for this. They had real heart failure, and we did exome sequencing and all that. It's CBLC causing it. They had non-compaction, and most of the time this doesn't do much. It can smolder along. For the cardiologists, there's a separate debate about what you do about this. And patients can have renal disease. And this is one you must remember. They can have all sorts of renal syndromes, glomerular syndromes, and thrombotic microangiopathy. And so you must consider this on the renal side when you're seeing patients that have atypical forms of hematuria plus or minus glomerular disease and hypertension, proteinuria. Don't forget this one, because if you don't treat with cobalamin, the renal disease will progress. Again, treatment guidelines coming from the European colleagues are a good read for those taking care of the patients. And again, what do you do now is you give them hydroxycobalamin. Do not give cyanocobalamin to the patients. You can also try to augment remethylation by using B10-folinic acid. Don't give cyanocobalamin. And there's a study that was published years ago by Hans Anderson showing that patients actually did worse when you give them cyanocobalamin. So don't do that. So what do we do really to treat the patients? We inject them with cobalamin. You can't take it orally. You must inject. Hard to tell moms and dads this, especially for babies. You have to inject them every day. So typically, again, this is a report of Dr. Anderson showing that the head basically starts growing when you switch over. That's a pretty fundamental outcome, brain growth. What we noticed in our cohort, this is unpublished, is over time, patients drift down with their cobalamin levels and drift up with toxic metabolites, including homocysteine. And so we look at this and you think about the dosing, and for peds, this is instinctive, how many mg per kg per day you get. And you can see here, these are the sorts of doses when we do infants by a standard regimen, they're getting about 0.3 mg per kg per day. Translate that to an adult, it's about 25 mg. That's about 40,000 times RDA. So these are huge, huge doses of cofactors we're giving the patients. And we published this paper years ago, and there's other people that have published on this as well, doing some careful studies to show how you must dose escalate and how this has a real effect. It's, we're giving super physiologic amounts and then more and more and more to get this biochemical response. And the patient, a single pioneer patient here who had low MMA, his MMA went down, his homocysteine went down, and his methionine went up. That's the pattern you want to see in response. So indeed, that's the case. There's a relationship. So the lower vitamin, these are all unpublished data from our study, the higher your levels are. The question is, how much should we give and what's the clinical benefit? This is the unknown part of it. So again, for people that are practicing in the community, and this is again something, a tricky one to do with your OB-GYN colleagues and your neonatology colleagues. Here's an example of a patient, a symptomatic patient. You can see quite affected. This is the management after diagnosis. This is her sister. But you have to treat the mothers with huge amounts of cobalamin early in pregnancy. So this is very tricky to do because it's, there's no FDA approval for this process. But if you don't do this, this little girl would look just like that. It's absolutely essential. So this is the maternal in utero prenatal effects of cobalamin, which are not fully understood, but critical for outcomes. So it even goes beyond that. People are doing now super mega cobalamin dosing, giving patients just the most unbelievable amounts of cobalamin to try to get them to respond. There's this paper written here, giving patients as much as 50 milligrams hydroxycobalamin a day. An adult with pernicious anemia might need 1 mg a month. We're giving 50 times that to a baby that weighs 20 to 30 times less than an adult. 5.5 mg per kg per day. That is just an unbelievable amount of cobalamin. And in these patients, some of them probably help their vision. That's the question. Does it help the vision? In our study, we found that it does, increasing the cobalamin dose does seem to increase neurocognitive performance. Again, there's still impairments, but the patients tend to do better like this. And there's an effect on vision, which I won't talk about. It's very controversial, but whether or not this can block the visual, block the maculopathy, seems like it might be the case. With respect to epi-CBLC, I wanted to mention this. I talked about it briefly, but if you see a patient, they look like it's cobalamin C deficiency, make sure when you work them up, the gene panel mutation analysis will look for the epi-CBLC mutation. These patients look exactly the same as classical CBLC. They have the exact same phenotype. It's a loss of function MMA-CHC, but you won't find it unless you look for this. And then the regulatory disorders I mentioned, which I'm not going to spend a lot of time going through, very, very severe clinical phenotypes. They have infantile spasms. This little boy actually had polymicrogyria. He needed a brain resection. So serious neurologic symptomatology, refractory to therapy too, by the way. And then the isolated hyperhomocysteinemia, I talked a little bit about these patients. Very severe early small heads, seizure disorders, bone marrow syndromes, megaloblastic anemia, terrifically bad hyperhomocysteinemia, difficult to control. And then they have a spectrum as well. And again, exactly what the history of these conditions is, the natural history. They're rare. We don't fully know. Putting into perspective for those who take care of hyperhomocystinemia patients, you can compare and contrast patients with cobalamin to those with CBS. Big difference here. This condition restrict methionine. This one, if you restrict methionine, their brains will not grow and they'll do much worse. So really fundamental differences to just emphasize to people taking care of these patients. And then this is also a sobering comment, which is you can do tremendous workups on patients and still end up not getting the answer. They can have methylmalonic acidemia. So you might find some of these patients, if you want to work them up together, we'd be glad to assist your efforts. These are patients that are probably going to need good old-fashioned cellular biochemical studies to figure out if they have it. We have such assays developed, which I'd be glad to talk about later on. Okay. So I'm going to close with these last few comments. I do have a few minutes, but this is a time to take a breath. We made it through a massive overview here of tour de force of inborn errors of metabolism for these conditions. And we're going to spend a second now to talk about what's next. We talked about how difficult the conditions are to manage, all the complications. It sort of says to people, it said to me many years ago to step back and say, we should be doing something better than what we're doing. It takes a long time. This requires research, animal models, patient research, collaborations. And it can it can have huge advances. So I'm showing you this. This is not MMA, but this is an important paradigm for us, especially in pediatric medicine. I'm showing you here a press release from a newborn screening that was recommended for spinal muscular atrophy type 1, SMA1, which, I take the clock back to when I was a fellow years ago. And it was very sad because we knew exactly what to tell moms and dads when the baby had SMA1. 100% chance of death by the age of 2, and a terrible time, really terrible time, downhill. Over the years, a gene therapy was developed for this condition that was effective. It was so effective that this got put on the newborn screen. And I'd be interested to hear from the audience how it's going here in Pittsburgh when you find a patient with this. It was FDA approved. This is Zolgensma. And it costs $2.1+ million per patient. And it's believed to be cost effective. So this is a separate debate, whether or not all these things I said are, I'm just telling you what I've read, and I don't take care of SMA1 patients, but I know I've seen many, and my heart goes out to the ones who are struggling with this condition. It's really a terrible one. But as we think about the paradigm this could set for us, which is, what are we going to do now for when we diagnose patients by our metabolic screening assays, which have been in place much longer than SMA, and we still don't have good treatments for the patients. Many of them do poorly. And then take it up a notch, which is what's happening, and it's going to continue to happen. And those who are interested in genomic medicine might want to read some of the papers that came out recently, again, from a Stephen Kingsmore's group, showing rapid genome sequencing for many, many genetic metabolic conditions, hundreds that you can do quickly and almost as quickly as you can traditional newborn screening. What are we going to do for those patients? So MMA is a good lesson for this, and that's one of the things I spent a lot of time working on. And years later, we have some new therapies from MMA. One of them is an mRNA therapy. I don't have the time to go through the details of how these were developed, the animal models, the research that went into it, huge amount of work. But basically, this is very interesting therapy. This is a lipid nanoparticle that contains the human methylmalonyl-CoA mutase, mRNA. It's given by IV infusion. This thing lands in the livers of mice, makes the enzyme, and makes a burst of enzyme, then goes away. So it's like ERT, but it's something new for the patients. Then there's a gene editing approach that uses nuclease-free editing to insert the mutase gene into the albumin locus and permanently edit the patient's liver. And Lou, this is almost, imagine this is not anywhere near as effective as a transplant, but it can produce liver-targeted gene expression. And then there's the last approach, which is about to roll out at NIH, which is a systemic AAV8 gene delivery approach using a novel immune modulatory agent that could allow us to potentially redose and make AAV a bit more safe. And this is a liver-directed approach. And each one of these has pros and cons, and I've listed them here. But I think I wanted to close by just mentioning that, for people that are working on a wide range of metabolic and genetic conditions that in infant newborn medicine and pediatrics, I think there is hope. I mean, there's really a new pathway forward for the patients. And it's going to change the way these patients are treated in the future. The example to cystic fibrosis could be made, and I'm not going to make that with any expertise, but just to say that there's new classes of medicines for cystic fibrosis that are revolutionizing the natural history of that condition. And for inborn errors of metabolism, I think we're going to be on the verge of this as well. And we look to the example of Zolgensma and SMA as proof that it will work. So with that, I will close. I went through an awful lot of stuff. If people want to send me an email with questions, please feel free to write to me. That's my email address. And I think I have 30 seconds or something for questions. No, I'm going to go. But anyways,